Okay, Dr. Northrup, ma'am, would you like to kick us off?
Sure. Welcome, everybody, to the September Grand Rounds. Got all kinds of good information. Dr. Chuck Mathers will be doing most of the presentations tonight, but I wanted to take advantage of your time and show you some of the numbers and some of the things we've been doing within the FAA for the aerospace medicine program. All right. So you've probably heard us say over the years that COVID has or since COVID, our numbers have really jumped. And this is just a graphical representation of that. Prior to COVID, we averaged 385,000 applications a year. Since then, we have climbed over 455,000. And if you look, the biggest growth is in the blue bar, that's the first class. And the largest number of those are actually young people under the age of 30. So the word has gotten out in a big way that we are, in fact, able to give a good career field in aviation. Now, in case you were curious what's been happening with the special issuances, last year we did almost 58,000 special issuances, which is pretty awesome. Um, so the thing we've been pushing, education, that's all levels of the aviation community through pilot minutes, the grand rounds, which you're attending this evening, articles, webinars, any place we can get a platform, we've been doing it to try to make sure that everybody along the line, from the brand new person that wants to become a pilot when he looks in the sky, all the way to the very, very mature statesmen in aviation, and then FAA employees, designees across the board. The other thing we're pushing really, really hard is early intervention, trying to get people the help they need before it becomes so drastic. And of course, we have these 7 barriers to seeking care that were in the mental health and medical clearance arc. If you haven't read it, I still encourage people to take a look at that. And finally, evolution of standards. So we really appreciate your help in making sure you come here for the grand rounds as we are once again in our usual cadence of the last Wednesday of the month. All right, bit of an eye chart, but what I want you to look at is the flow of the bars. On the first of the year, we began to really work on the backlogs. And you may recall that earlier in the year, we were up close to 13,000 deferred unissued cases. And this is from 10 days ago. We are below 6,000 at this point. Now, the blue bar is general review, so 61% of all cases go into the general review queue. The orange is drug and alcohol. The green is medical appeals, meaning the 15 mandatory deniable. And the blue at the top is the neuropsych cases. So we've made huge headways into this. Again, don't worry about the numbers. Look at the graph and the way it's going. But as we've gotten it down to under 6,000, it allows us to really look hard at where those cases are and who has them. We didn't start tracking this until March 31st. So I can't go back before that, but I can tell you the salmon color in the middle are the number of cases sitting in a physician's box or in a queue waiting for a physician to pick it up. If you go back to the 1st of January, there were nearly 8,000 cases just waiting for a doctor to look at it, plus the ones that were in physician queues. And we've been consistently under 500 with those. And in fact, the fetch queues waiting for a doctor to pick it up are way, way down. There was actually a day last week where there were no cases waiting for a physician to pick it up. The blue bar on the bottom are the cases that are waiting for either a legal instrument examiner or a program analyst to pick it up. So again, those are way down, almost a 50%. In fact, it's more than a 50% decrease. So thank your analyst when you talk to them or your LIE. But what that uncovered at this point is more than 50% of the cases we are waiting for the airman to send us something. So we've switched our focus over the past year to something else. Now, just in case you hear that there are these thousands of cases that are over 2 years old waiting for us to pick them up, that is not the case. As of a week and a half ago, there were only 25 cases that were over 365 days. This week, we're down to 24. And no cases over 2 years old in the deferred unissued cases. So we've made incredible strides in this program. But where I need your help now is in getting pilots to pre-flight their medicals. So when I talk to pilot groups, I usually start with how many of you are pilots. And given that I talked to GAJSC and Oshkosh, and I just did a presentation for the National Association of Flight Instructors, I was at the ALPA Safety Conference, mostly pilots. And when you talk about it to them, did you get ready for your check ride? Did you read the regulations? Did you do a couple practice flights? Did you get in a simulator and make sure you knew where everything was? Did you practice your orals? Oh, yeah. Everybody does that. How many of you own airplanes? About half the audience typically has an airplane that they're at least fractional owners in. Well, when you change something, you talk to your A&P mechanic. You talk to an IA. You make sure you fill out your 337. That's how you tell the FAA you're changing your airplane. Make sure everything was filled out right. Well, yeah. And then I look at them and I go, so how come so few of us pre-flight our medicals? It's the check ride for your body. And I usually get dumbfounded stares. It's an open book test. And if you don't know the answer, your AME probably does or can find it, or there's a whole bunch of pilot advocacy groups that can help. And we're going to help you too. So if you haven't seen them, these are the changes in MedExpress. This is what the landing page used to look like. This is what it looks like now. Essentially, we ask them, are you a first-time applicant or have you had a change in your medical condition? If the answer is yes, please look at these documents. The first one is a how to use the guide for aviation medical examiners written by our interns last year. Bells and whistles and QR codes. It's an awesome thing. A link to the guide for aviation medical examiners and then medical certification information. These documents are continue to be modified. And we're going to start working on the frequently asked questions to make it more user-friendly. The dreaded question 18, we've modified it. Let me blow that up for you. So that at the bottom of the page, before they hit next, did you answer yes? Please go to the AME guide to identify what you should take to your AME. Former confirmation page. This is it now. Again, we ask them 3 times, or encourage them, I guess is a better way to put it, to go look at what you need to bring. We've updated the help menus. We've updated the frequently asked questions. And why is this important? Come on. One more. There you go. We started tracking, and once we got our numbers down some, we can seriously look at what we call the first pass effect. So the upper, I know this is a bit of an eye chart, the upper left-hand quadrant is our general review fetch queue. 61% of all cases go into this queue that are deferred. The green line is the average time from your deferral to our decision for these cases. 10 days ago, it was 17.9 days. And that's not CAMI days. That's from the time you deferred till we made a decision. The red line is the average if you had to go into a hold queue because we needed to ask for something. I used to say every time I send a letter, it increased the time from 6 to 8 weeks. I was wrong. I was drastically underestimating. It's closer to 110 to 120 days. So stack on 4 months. The other ones, medical appeals is right below the GR. Drug and alcohol is the upper on the right with neuropsych on the bottom. The other ones are a little higher. They're trending by and large the correct direction. But still, look at the difference between the first pass and if I have to ask for information. So this is pretty powerful. And if you can encourage your pilots to be ready, when they walk in and you upload, we have a much better chance of getting them back to work or back in the air quickly as opposed to having to go back and forth. All right, let me stop sharing. And I'm going to turn it back over to Christy after I say thank you to you all for being here. I really appreciate your getting online late in the day for many of us or trying to interfere with dinner for others. But thank you again. You really are where the rubber meets the road as we make sure we keep the national airspace system safe. All right, Christy, back to you.
Okay, thank you so much, Dr. Northrup. Next slide, please. All right, this is our standard housekeeping. If you've joined with us in previous Grand Round sessions, you know that the session is being recorded. No participants will be shown in the recording, and we will make that recording available later via our YouTube channel. Now, if you are new to AME Grand Rounds, I do want to take a second to tell you that if you are ever curious and want to go back and look at those previous Grand Round sessions, the easiest way to locate those is to open up your favorite internet browser and then into your favorite internet search engine or the address bar. If you'll just search for FAA AME Grand Rounds, it should give you the very first link should be the YouTube link for our playlist. Keep in mind that all of those recordings were current as of the time of recording. Next slide, please. The rules of engagement. Our session is now locked because we do lock the session after the first 10 minutes. Our accreditation allows us to grant you, as a physician, 1 full hour of free CME each month that you attend. If for some reason you drop out of the Zoom session, you may not be able to rejoin. You can try sending an email to amenotifications@faa.gov, and we may be able to readmit you depending on the timing of it. But keep in mind the room is now locked, so you'll have to send that email in order to try and get back in if you drop. Your chat, your cameras, all of those are disabled. We want to capture your questions using the Q&A button at the bottom of the Zoom screen. If you are new to the Zoom environment, please take a minute to familiarize yourself. If you'll take a look at your screen, whether that's a phone or a computer or an iPad, depending on the size of your screen, you may have a Q&A button easily found on your screen. If you don't see it, you usually have a More button. If you click the More button, that's where you're going to find that Q&A if it isn't already on your screen. We also ask that you would limit your questions to the topics being discussed this evening. We have quite a few updates to the AME guide this month, and we want to make sure that we're able to answer all of your questions. Quite a few of our regional flight surgeons and FAA docs are on the Zoom session this evening, and they will be answering questions throughout the time. And we'll also have a time for Q&A at the end of the session. Also, as part of our accreditation, we do have to state if any of our speakers have any financial disclosures that they need to announce. And this is our statement for this recording, that no speakers have any prohibited relationships to disclose. Next slide, please. What's our objective for this evening? Well, in addition to all of the great news Dr. Northrup shared, our primary goal this evening is to discuss the September 2025 AME guide updates that were released today. And with that, I'm going to turn it over to Dr. Charles Mathers. Dr. Mathers, it's all yours.
All right, good evening, everybody. Welcome to AME Grand Rounds. We have a lot to cover, so I'm going to go ahead and get started. An overview of tonight's session, we're going to discuss several AME guide updates. We have 3 new conditions in the guide: pulmonary fibrosis, sarcoidosis, and Cushing syndrome/disease. These do show up in the AME guide, but they're conditions where we just basically say defer and send us all the information. So consistent with what Dr. Northrup was saying about how to pre-flight your medical, we wanted to give some more definitive information about what we need for each of these conditions so that you have a better idea of what to submit and hopefully make the case processing more efficient. We also have some updates to existing conditions, cataracts, some neuro conditions, as well as a update to color vision. And then I'm going to close with an update to the Asthma CACI, as well as an update to the low testosterone hypogonadism policy. Okay, we're going to get started with pulmonary fibrosis. So I'm not going to go into detail about what pulmonary fibrosis is. We're going to focus mainly on the aeromedical concerns. So obviously, pulmonary fibrosis causes scarring of the lungs. This can lead to symptoms of shortness of breath, dyspnea on exertion, and fatigue. And over time, they can develop pulmonary hypertension, heart failure, and hypoxia, all of which are not good in the aviation environment. So for row A for pulmonary fibrosis, this is going to be for idiopathic pulmonary fibrosis. Going to need to defer all these cases. We're going to need a DCPN from a specialist, in this case, a pulmonologist, which must include the current disease severity, a GAP score. This is a prognostic score that gives us an idea about how they're doing, and a history of any acute exacerbations or other complications. We also need a pulmonary function test, full PFTs with DLCO performed within 90 days, a current 6-minute walk test per FAA protocol, and then results of testing or imaging already performed, such as a high-resolution CT scan or ABGs if they were done. Row B is going to be for secondary pulmonary fibrosis. Also need to defer in this case. And this is due to pulmonary fibrosis that's from an underlying cause. And the simplest way to explain this is someone has cancer, they undergo chemotherapy, that chemotherapy leads to pulmonary fibrosis, and so that would be a secondary cause. We're still going to need all the items in row A, but we're going to want you to see the corresponding AME guide page for the underlying cause. So you would refer to the AME guide page, find the cancer that they had, and follow that guidance. Okay, moving on to our next condition. Sarcoidosis is pretty complex. It's a multi-system disease, has several aeromedical concerns. The acute ones include chest pain, shortness of breath, hypoxia, sudden incapacitation, ventricular arrhythmias, and seizures. Chronically, it can cause heart failure, cognitive abnormalities, and visual impairment. Now, there are certain sarcoidosis cases that we might be able to get to the point where the AME can issue, and that is in early stage, so pulmonary stage 1, and this is lung involvement only. So there are certain cases of sarcoidosis that are just confined to the lungs. It's early stage 1. And in this case, we have completed a sarcoidosis status summary, and we'll go over that in detail in a minute. So if the AME can issue these cases if all items fall into the no or stage 1 column, if the individual meets visual standards, and the AME has no concerns. So here's what the sarcoid or sarcoidosis status summary looks like. You can see that we request a note from a pulmonologist or a physician who treats your sarcoidosis. So in this case, we do allow either a pulmonologist or the treating physician to complete this. And what we want to see is we want to see no's on all of these. So the first question is stage 2 pulmonary sarcoidosis or higher. So we want to see a no there. We want to see it be stage 1. Is there any other organ involvement? So again, we want to know there. We want it just confined to the lungs. Symptomatic or in remission for less than 2 years, we want to know there. We chose 2 years for clinical stability because that's the time when usually we'll see the condition go into remission, and so that's why you'll see that number. Required oral corticosteroids or systemic immunosuppression ever. So stage 1 sarcoidosis is usually treated with like an inhaled steroid, if at all. And so any evidence of systemic steroids is usually indicative of more complex disease. So we want to see a no there. Any evidence of heart block or arrhythmia, obviously that would be bad. Tuberculosis testing, typically in sarcoidosis patients, they undergo TB testing if it's in the lungs. So we want to see that be a no. And then any other clinical concerns. So if it's one of these stage 1 sarcoidosis patients and you're able to answer no to all of these questions, you can go ahead and issue. At the bottom, you'll see AME actions. You can go ahead and issue a certificate if they're otherwise qualified. You want to submit this summary or a detailed clinical progress note that covers all these things and all the supporting documentation reviewed to the FAA so that we can confirm everything is good to go. Okay, row B is going to be for anything other than stage 1. So this is going to be pulmonary stage 2 or greater, or any other organ involvement, or sarcoidosis with hypercalcemia. So hypercalcemia is a marker for more severe disease. It can lead to things like renal failure and nephrocalcinosis. And so that's a marker of more serious disease. You're going to obviously want to defer all of these cases. For these row B cases, there's a lot of stuff here. But again, this is a multi-system disease, and we need to make sure that the more serious things, such as cardiac and neurosarcoidosis, are ruled out. Again, I mentioned that right now it says just submit everything. So hopefully this gives a more refined list of what we're going to need. We're going to need a DCPN, a detailed clinical progress note from a pulmonologist, rheumatologist, or internist. So we're giving a variety of specialists that they can go see. Labs, which you'll see there, chest x-ray, and the most recent CT chest, if performed. Any pathology results, TB testing if pulmonary sarcoidosis is present. Again, we're going to need full PFTs, pulmonary function testing with DLCO, 6-minute walk test, an eye evaluation by an ophthalmologist, a 12-lead ECG, a cardiac monitoring study of at least 24 hours. That's to make sure that they're not having any ventricular arrhythmias. And then most recent MRI brain with contrast. So if cardiac sarcoid is present, the testing that was done on the previous slide was just to make sure those things aren't present. But if cardiac sarcoidosis is confirmed, we're going to need all the items from row B, plus specifically a progress note from a cardiologist, the most recent echocardiogram, the most recent cardiac MRI that should have been done for cardiac sarcoid patients. And then in replacement of the 24-hour cardiac monitor, we would need a cardiac monitoring study of at least 30 days. If neurologic sarcoidosis is present, again, all items in row B, and then a neurologic evaluation per FAA specifications within 90 days, a brain MRI with contrast since the initial diagnosis, or the most recent brain MRI if new symptoms have developed since the last evaluation. Of course, we'll want all the neuroimaging on CD. And then if a lumbar puncture was performed, we'll want to see those results. Okay, moving on to our next condition, which is Cushing syndrome/disease. There's a lot of aeromedical concerns with this as well. This can lead to development of or increased risk for cardiovascular disease, glucose intolerance or diabetes, OSA, muscle weakness, kidney stones, visual problems. And interestingly, Cushing's syndrome and disease can cause neurocognitive impairment, which actually may not return to baseline even after correction of the hypercortisolism. So row A here, again, you're going to want to defer these cases. These cover the Cushing syndrome cases, so iatrogenic from glucocorticoids, ectopic ACTH syndrome, or syndrome due to an adrenal tumor. We're going to need a DCPN, detailed clinical progress note, from an endocrinologist, labs to include a hemoglobin A1C, and then any other testing deemed indicated. If surgery was performed, such as to remove an adrenal tumor, we'll need the operative and pathology reports. Now, Cushing's disease due to a pituitary adenoma, we're going to need all of that row A information plus visual field graphs. You'll note that there is currently not a specific page for pituitary micro and macroadenoma in the AME guide. We actually do have a page that will be published very shortly. We're working on that right now, and so stay tuned for more information about that. Regarding the neuropsychological impairment that can be seen in Cushing's, we are not going to require a neuropsychological evaluation, but we are putting a statement in the AME guide says that in some cases, a neuropsychological evaluation may be required. And that's, again, because the cognitive impairment that can happen with this may not return to baseline even after correction of hypercortisolism. But again, not required, but we may ask for it. Okay, that covers the 3 new conditions. We're going to go over a few updates to some existing ones. For cataracts, we've revised the disposition table in row B to add a note. The note says if they're unable to meet first or second class visual acuity standards, but they will accept a lower class, the AME should issue a third class and annotate in block 60. So that gives pilots some options if they don't meet first or second class visual acuity standards. Okay, moving on to neurology, a couple quick updates here. For head injury or brain injury, we removed the requirement for an EEG as required for row D, severe brain injury. We got a good question in the last group at noon that EEG still shows up in row C, but that's only in specific circumstances. So we removed it as a requirement for the row D. Neurofibromatosis. We clarified that visual fields must have an interpretation and can be either Humphrey 30-2 or 24-2 with good reliability. And then headache or migraine, we revised row B and C, the column names, just to update some terminology. These terminologies get updated sometimes, and it just needed a refresh. Okay, color vision. So a big shout out to the AMEs in the audience. This was actually a change that was recommended by you to make things more clear, and we really appreciate your input. So you'll notice, you've probably looked at this table quite a bit. You'll notice that this is the section that has changed right here. This used to just be one box, and now we have two. So we've clarified in this green box that if it's a returning pilot that has previously passed an FAA-approved color vision test and held any class of medical certificate without a color vision limitation, SOTA or LOE, computer-based color vision screening is not required. So hopefully that will make things a little more clear for the people in that group. Okay, my last couple conditions are going to be on asthma and low T. We're going to start with asthma. So asthma, for a long time, if you've looked at that sheet, for the folks that are on a maintenance medication and need some sort of pulmonary function test, it said PFTs for a long time. We've clarified that spirometry alone is acceptable. So for most garden variety asthma, we could just do spirometry. We don't want them to have to go off and get full PFTs. So we've made that clarification, and spirometry is acceptable for doing the test in CACI. We've also made a change to the spirometry criteria. So currently, or actually prior to today, it said FEV1, FVC, and FEV1 over FVC all have to be above 80%. So this has always kind of bugged me because FEV1 over FVC is how you diagnose asthma. It's how you show airflow limitation. So it's not really used in to assess the severity of it. So we've removed that. So FEV1 over FVC is no longer there. The ones that, so the statement has changed to FEV1 and FVC are both equal to or greater than 80% predicted before bronchodilators. You may be asking a question, why is FVC still there? We typically just use FEV1. We left FVC on there for CACI because if FVC is below 80%, that can be indicative of more of a restrictive problem or some other process going on. So for CACI, we just wanted to make sure that FEV is still above 80%. But hopefully those changes will make things a little easier for y'all. We have also added a new row A to the asthma disposition table. So as you know, a lot of people have childhood asthma that has resolved or have it, from a specific trigger. And we've clarified that in these specific circumstances, you can issue, and these do not require a CACI. So the first is a history of childhood asthma that has resolved. Second is asthma caused by a specific and avoidable trigger. So this would be like a pet exposure, specific foods that's managed by avoidance, and you only need a PRN rescue inhaler, or exercise-induced bronchoconstriction, also known as exercise-induced asthma, that's treated with a PRN rescue inhaler only. So in these circumstances, you can issue, and the pilot will get a warning. No CACI required. Okay. Last topic is low testosterone hypogonadism. Many of you probably saw a couple of months ago, the FDA removed the black box warning about an increased risk of cardiovascular disease from testosterone products, and that was based on the findings of the TRAVERSE study. So we have followed suit and removed cardiovascular disease as an excluder from the CACI. Now, any history of VTE or venous thromboembolic event, such as a pulmonary embolism or a DVT, still does not qualify for a CACI, and that's based on, we took another look at the research, and there's been meta-analyses, and even the TRAVERSE study authors themselves put, and this is a quote from their study, our findings support current guidelines that testosterone should be used with caution in men who have had previous thromboembolic events. There were actually an increase in pulmonary embolism in that study, and so the authors are recommending caution. So again, we can probably still get to yes in that circumstance, but that's not a simple kind of CACI-able condition, so we're not going to qualify that for CACI. But the good news is that we removed cardiovascular disease as an excluder. So on the AASI worksheet, we've made a change to the deferral criteria. Now, we recognize that there may be some circumstances where, let's say, someone has had a very provoked type DVT or PE, maybe from like a major trauma. They don't have any ongoing risk factors, and they're taking a testosterone product. So if that's the case, we're still going to want to see it the first time. So, they still won't qualify for CACI. We would need to see, the first time they have that history, we'd still need to review it. But we're leaving it open that those pilots could be followed on AASI if they've had a previous history of VTE. And so the deferral criteria has been changed to develops any new venous thromboembolic event. So this gives an option for AASI as well. Lastly, another piece of good news, we've removed prostate cancer as an excluder from CACI. So as many of you all know, prostate cancer and testosterone, the research has become a little bit mixed. It used to be that you would never prescribe testosterone to a patient with prostate cancer history. That's kind of changing as the research evolves, and so we felt like it was okay to remove this from the CACI. And then if someone has this prostate cancer history and is on a testosterone product, you can just follow the AME guidance for prostate cancer. So again, prostate cancer is now no longer an excluder from CACI. Okay, that concludes my formal presentation. We really appreciate all the feedback that we get from you all, and so I'll be standing by for questions. Thank you.
Okay. As always, we like to show you the email inbox. If you have suggestions for improving the AME guide, that email address is AMEguide, all caps, at FAA.gov. Keep in mind that this box does not answer any case questions. It is for suggestions for improvement only. And I personally have seen, just in the short amount of time I've been with aerospace medicine, some improvement. So your suggestions are being heard. Next slide, please. Okay, thank you all for coming. I'll echo what Dr. Northrup and Dr. Wyrick always say. We appreciate your time. We appreciate your service as an AME. We don't take that lightly, and we appreciate all that you do. Dr. Northrup, would you like to say goodbye before we kick everybody to the breakout rooms?
Actually, I'll let Dr. Wyrick take this one.
Excellent.
Thank you, ma'am. And again, thank you for joining us and so late in the day. We hope that this information was helpful to you. And again, we appreciate your service as an aviation medical examiner. And you guys are at the point of the spear. And we always say it, when you look up in the sky and you see a contrail, you had something to do with that. Thank you again for all that you do. And thanks for sticking with us. Good night, everybody.